Welcome to the Practicing Clinicians Exchange podcast series on strategies for individualizing the management of inflammatory bowel disease. This is the third of 4 podcast episodes, adapted from a presentation conducted during a PCE Gastroenterology APP bootcamp in April 2022. Each episode is eligible for CE or CME credit. To receive your credit at the conclusion of the podcast, please go to pce.is/IBD or click the link in the podcast notes. This episode is certified for 0.25 ANCC contact hours and 0.25 AAPA credits. In this episode, gastroenterologist Dr. Anita Afzali and gastroenterology MP Dr. Nana Bernasko will explore challenges with medication efficacy and response rates, therapeutic drug monitoring, de-escalation strategies, and principles of shared decision-making. Now, let's get started as Dr. Afzali will begin by discussing treatment challenges.
The most effective and robust literature and data that we have on achieving deep healing, endoscopic healing, is our TNF antagonist. But also recognizing that despite that, our TNF antagonists are not great, in a sense of recognizing that our patients, about 30% risk of patients being a primary non-responder to our TNF agents. This is unfortunate because we have evidence that it tells us it's effective. We have evidence that achieves mucosal healing. This is early appropriate therapy, but about 30% of patients may not respond to a TNF antagonist. So bear that in mind, and then also recognize that there's also that risk, whether our patient is on infliximab, adalimumab, golimumab, certolizumab, these TNF agents, these patients are still at a risk of losing a response, even if they initially had a response to the respective TNF agent. So 30% may not have a response to our TNFs, regardless of which one we've chosen for the appropriate patient. But then the rest are at risk of developing a loss of response. And this is oftentimes because they've developed antibodies to the TNF, the respective TNF agent, or potentially it's a mechanistic failure where the patient, regardless of having adequate drug levels of the TNF agent, their inflammatory cascade is being driven by something else, some other mediator, some other inflammatory mediator that's not TNF driven. So when we're trying to distinguish primary non-response from secondary non-response, in our minds, we need to differentiate of, is this a patient who just never responded? I have appropriate drug levels. I know that this patient is on a TNF. I see that there's drug in their system, but we're not seeing an improvement in the biomarkers, calprotectin, CRP. When you perform the next colonoscopy, you're not seeing any improvement in endoscopic evaluation, and certainly no improvement in symptoms. This patient is a primary non-responder to TNF agents, and you should consider a non-TNF biologic. The non-immune mediated pharmacokinetic failure patient, a patient with inflammatory bowel disease that does not adequately respond to therapy in the context of having a subtherapeutic drug level, maybe despite how much more you're trying to optimize their TNF agent, they just have such a high inflammatory burden where you need to potentially either do combination therapy or switch them all together because they're just not able to respond to no matter how much TNF agents you're giving them. And then the immune-mediated pharmacokinetic failure patient is a patient who's developed high levels of antibodies. So really a significant amount of resistance to the TNF agent. And this patient is at a higher risk of having bad outcomes related to that respective TNF agent, such as an infusion reaction with infliximab if they have high antibodies. So these are the ways to differentiate whether your patient is a primary non-responder, they've never responded, or secondary loss of response, meaning they initially had a good response, but now because of antibodies or subtherapeutic drug levels, they're losing a response. And you need to optimize their medications and or change or switch. So what are these factors? What should we consider when we're talking about which of our patients will lose a response or have adverse reaction to an infusion, for example, because of a suggestion of developing antibodies? Well, first and foremost, remember a drug, any drug will only work if there's adequate amount in your system. So the drug bioavailability matters. And this is based off of if you have a significant inflammatory burden, high CRP, if you have a significant amount of antibodies, for example, if you have a higher body mass index, for example, a low albumin where you're unable to absorb the drug, you have less drug in your system. So it's unlikely to work because you have less drug in your system. Again, when we're talking about therapeutic drug monitoring, this allows us to check drug levels as well as check antibody levels to the TNF agent in order to determine, do we need more drug in the system because of a subtherapeutic level, or is there's just so much antibodies that no matter how much drug we give, the antibodies will capture the drug and not allow it to be effective because now there's a high clearance of drug related to the presence of antibodies. So it's important to distinguish these factors in your patient once you've started a TNF agent to recognize why potentially they're a non-responder or have developed a loss of response to the respective agent. And so when we talk about the different therapies, there are some special considerations for patients of which treatment you may want to reach into that medicine cabinet for. For example, our older patients, by older, I mean greater than the age of 65, these patients might be at a higher risk for infections. We know this just because of life, a higher risk of infection, higher risk for malignancy. So these patients should, if you could, consider vedolizumab or ustekinumab because of their safety profile. It may be more appropriate than a TNF agent, recognizing that there's a higher risk of infections and malignancy associated with our TNFs. Higher risk is still a low number, but we need to recognize that older age places our patients already at a higher risk for malignancy or infection, respectively. What about our inpatients? Well, for these inpatients, again, you want to consider rapidity of onset. And so that infliximab might be the appropriate agent for that acute severe ulcerative colitis patient who may have just maybe you just made that diagnosis in the hospital, or they went previously from mild moderate to disease to now severe disease, and you're hospitalizing them to give them fluids and steroids, and you're ruling out an infection. You're probably going to have to reach in for that infliximab as a new start. Cyclosporin has also and should also still be considered as a treatment option, particularly if there's a low albumin, recognizing, again, a drug only works if it's in your system, and infliximab in the setting of a very low albumin may not be as effective. Again, for the patient who has a prior malignancy history, veto or UC might be appropriate. We have more than enough data now related to pregnancy that tells us whether it's our biologics or our thiopurines, it is safe. Healthy mother equals healthy baby. Control the inflammation, continue these medications throughout pregnancy and even postpartum, recognizing that that results in the best outcomes for our patients. For that mild, moderate, steroid responsive therapy who might just absolutely not want to be on a biologic, a thiopurine, if they're steroid responsive, may still be considered, and this is per their guidelines and recommendations. For the patient who has extraintestinal manifestations, as I discussed, you want to take a medication that has dual indications, a TNF antagonist or tofacitinib. And then for the prior TNF failure, ustekinumab or tofacitinib should be considered in the appropriate patient. So taking the consideration of the drug levels, this is where we want to ensure that if you are considering de-escalation of therapy, this is the time where you want to make sure that your patient is on the right therapy before you consider de-escalating anything. Again, when we're doing combination therapy, and if you're considering de-escalation, it should be your immunomodulator as far as stopping or removing, and not your biologic, because that's the biologic is what helped achieve the mucosal healing and that deep remission. There's two approaches for therapeutic drug monitoring. The reactive approach is your patient, you've started them on the treatment, and now they've potentially, for whatever reason, are not doing as well as they initially did. And you're trying to figure out, were they a primary loss of response or maybe a secondary loss of response because they initially felt well? This is that reactive approach. The proactive approach is basically saying that we're not going to wait for evaluation of whether the patient is going to lose a response or not do well. We're actually going to be, as the word implies, proactive. So after potentially induction of therapy, you're already proactively checking drug levels and even potentially antibodies in order to determine if you have the right dose for the right patient. Again, this is that practice of personalized medicine in IBD, where we're determining which treatment we're going to choose. We know and we've identified different factors, inflammatory burden, et cetera, and we want to ensure that they have enough drug in their system. Remember what I said, the drug only works if it's in your system. And if you take that proactive approach, you're optimizing trough levels, drug levels early on in order to ensure that your patient will continue to have a good response in therapy. Now, this proactive approach, certainly we've practiced proactive therapeutic drug monitoring with other medications for other disease states. For example, in organ transplant, tacrolimus levels, you might be familiar with it. This is oftentimes checked in order to ensure that the patient is on the appropriate dosing post-transplant. Vancomycin for infectious conditions. So certainly there is a consideration and more conversation, and shall I even say debate, in regards to the utility and timing of when we should be checking drug levels or antibody levels. And there's more and more literature and research that's telling us and maybe potentially helping advise us on whether we should or should not be proactively checking and performing therapeutic drug monitoring. If you are considering a proactive therapeutic drug level monitoring, all in all, I would encourage you to have the key take-home point, which is a level of 0 is most meaningful. Otherwise, you should be aiming for a level of 10 for infliximab or adalimumab. And then what we don't know is with these other medications that are non-TNFs, we don't know really what to make of drug levels. But all in all, ensure that your patient has the appropriate medication and they're responding to it. And if they're not, then perhaps at least a reactive therapeutic drug approach, monitoring approach would be the most appropriate.
So next, we'll talk about shared decision-making. I can't stress enough how important this aspect is. I unfortunately learned the wrong way over time and adapted my clinical practice to really involve shared decision-making. Why is this so important? Well, patients desire more support information at diagnosis. Shared decision-making improves adherence and satisfaction. Patients with IBD prioritize efficacy of therapy and decisions. We want to talk to our patients about the risk and benefits of being on these medications. However, we have to get them to understand, whether it's using visual aids, absolute numbers, just break it down so they understand why they're doing what they're doing. And then we want to also talk about safety profiles, which are available for all our IBD agents, because each medicine may be different. A lot of times patients come in and you would prescribe a medicine, maybe like a sub-Q injection, only to find out later that they're afraid of needles. And so then they don't give themselves the medication. So it's so important. I do this all the time when I'm trying to figure out a treatment plan for my patient. I get their involvement in it and I make sure they understand why we're doing what we're doing. Because as I said before, it really does improve adherence and satisfaction. And do IBD patients feel it is to be involved with medical decisions? Well, in this study that was done by Siegel, about 81% of patients said it was very important to be involved in their medical decision. Well, that would make sense. We are making decisions about their lives. This is something they're committed to for the rest of their lives. So again, it's so important to get them involved when we're talking about medication treatments. So next, we'll talk about de-escalation therapy. So why would we do this? Well, the pros of de-escalating therapy include, reducing the risk of adverse events, right? Including infections, malignancy. As Dr. Afzali mentioned before, sometimes these medications are really expensive and we want to be able to make sure that the patients do stick to the medication regimen for whatever reason. We want to make sure that we're giving them what they need at the right time. So if they're not needed, then perhaps we can discontinue those medications. Other negative effects of de-escalation, it could be because loss of biologic drug efficacy. They can increase the risk of relapse, right? And when we take one medication away, such as thiopurines, we may increase the development of anti-drug antibodies. So things to consider when de-escalating therapy. First of all, you want to make sure your patient is remission, not just remission, but deep remission. This includes clinical and endoscopic remission. You're not listening to just what the patient is telling you. You have objective evidence to show that your patient is in deep remission. And then consider therapeutic drug monitoring. Now, this sentence is a little bit misleading. So it says low trough level rates are associated with low rates of relapse after de-escalation. Now, you're looking at your patient who is probably got a therapeutic level of what would be considered below what would be normal. You do a colonoscopy, you do whatever imaging study, you show that they're in deep remission. Well, this basically says that because the trough levels are low, perhaps the patient actually does not need that medication. So you can go ahead and discontinue that medication because those trough levels not high enough to actually achieve remission. So if your patient is already in remission, endoscopically confirmed, objectively confirmed, but they have low drug levels, then the drug is doing nothing. Therefore, you can go ahead and safely discontinue that medication. And then you want to actively monitor for relapse and have a plan for retreatment, right? When you stop these medications, you're not saying, see ya in 3 years. You want to have a plan set up so that you can catch that patient early enough before they run into trouble if they should flare. All right. So treatment de-escalation, you should continue the biologic agent. If they're on dual therapy, you want to consider decreasing or stopping that immunomodulator or the 5-ASAs. Prior to de-escalation, you want to confirm endoscopic remission. You want to make sure that the labs are normal. You want to optimize your medication. So again, look at drug levels, make sure that those are optimized, and then you can take away that second agent. You want to monitor. Again, make sure you have a plan set up with that patient so you're able to rescue them if they should fall into problems. So key takeaway, have a clear monitoring and therapeutic plan in place prior to de-escalation. Talk to your patient, make sure you have a plan, and when that plan doesn't go as scheduled, you have a plan B ready to move forward.
Thank you very much, Drs. Afzali and Bernasko, for that excellent discussion, and thank you to the listeners for joining us today. Tune in to the other episodes in this series to learn about diagnosis and classification, treatment goals and targets, medication options, evidence-based health maintenance, and much more. You can access those as well as claim your credit for this episode by visiting pce.is/IBD.